Good evening. I'm not really sure if I need a microphone, but I sound so much better on a microphone. Welcome. You are at Medicine Assisted Treatment, put on to you by Suncoast Institute on Chemical Dependency. Tonight we're going to be talking with some panelists about how medicine assisted treatment can help with recovery and with substance use disorder. My name is Linda Christensen. I am the Executive Director of Educational Programs for Suncoast Institute on Chemical Dependency. We are a nonprofit, faith-based organization that offer free educational programs on addiction, recovery, and prevention to all organizations, congregations, individuals, and communities who are working with individuals and loved ones with substance use disorder. Tonight's topic is going to be how medicine-assisted treatment can help with people in recovery. And I would just for a minute like to acknowledge Robin Hain as our president. We have Jewel and Alan Maringer, who were our original founders. We have Jennifer Fred Smith, who's with us. We have Liliana. We have Suri. And we have our audience and panel. I'm going to let Dane do the rest of the introductions with the panel. And Dane is our moderator. He is with the University of Southern Florida, and he is the assistant professor and endowment chair of the Evelyn Duval Family Development. Did I do that right?
You did.
All right. It's a long title. It's like one of these, like Suncoast Institute on Chemical Dependency. I like to have it shortened. So we are going to, before I introduce this, we're going to start with prayer, and Jennifer is going to offer the prayer.
Thank you all for coming and being here. This is a topic that's near and dear to my heart, so we'll just flip it up. Dear, I would just thank you for all of the wonderful people that are in this room, Father, that have the mission to make our community healthier in understanding addiction, Father. We just thank you and we praise you for all the things that you are going to do tonight. Amen.
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 Thank you, Jennifer. Thank you, Jennifer. And with that, I will hand the microphone to Dane.
All right. Thank you. Can everybody hear me? I have a teacher voice, so I just tend to project. It was a little scratchy, and y'all probably be able to hear that better with me anyways. So yes, thank you for the introduction. The title is a lot cooler than, or it sounds a lot cooler than what it is. It is kind of long. My background is been in addictions for a long time. Prior to coming to USF, I was the director for the Ball State Center for Substance Use Research and Community Initiatives, and I also spent some time as the Bureau Chief of Prevention for the state of Indiana, which actually had a lot to do, well, some to do with the MAP programming within that state, which I can say looks vastly different from this state and also from some of the other areas like New York. So this was kind of eye-opening for me, and getting a chance to look this up and see what some of the regulations and statutes and challenges and the benefits of being in Florida are related to this topic. So first off, I guess thank you all for coming. Again, it's really important, timely information, and hopefully we can do a good job talking about this topic. Really, we're going to try to explore some of the complexities, the benefits, and the challenges with MAT and addressing substance abuse. Even if MAT, I don't even know if that's the right terminology anymore. I'm pretty sure we were having previous discussions on this, and I was getting all sorts of new information. So it is going to be good. We have a great panel here, and since we got such a small group, it's kind of more of almost like a fireside chat, which is awesome because y'all can just shout out questions, and I don't have to like point at people and walk around with the mic, which helps out too. But because we got such a small group, I'm going to go ahead and let the panelists introduce themselves, just because they can do a better job of that than me. We'll start out right here with Jonathan. If you can tell us your name and your experience with MAT.
Sure. Hello, everyone. I'm John Essenberg. I'm the Chief Business Officer for Operation PAR. I graduated from Princeton University with a degree in psychology. Started working at PAR in 2010 as a counselor. I was the program director for the clinic in Sarasota for a couple of years, and currently I provide the administrative oversight of all of Operation PAR's opioid treatment programs up and down the west coast of Florida. Collectively, we have about 3,500 active patients, the majority of which are in methadone treatment. And yeah, I've been doing this for about 14 years, so I'm pretty passionate about it, and really excited to educate you all on this very timely topic.
Excellent, thank you. Krista.
Hi, everybody. My name is Krista Snyder. I'm the Program Director of New Seasons in Sarasota down on Clark Road. I've been working in substance abuse treatment for the past 13 years, and I've been the Program Director of New Seasons Sarasota for 2. I've been working specifically with methadone and Suboxone treatment for 8 years now.
Thank you for being here. Elizabeth.
So my name is Elizabeth Davis, and I say where I work and stuff, or just talk about.
You can talk about where you work, whatever your connection is with the topic and the information that our audience can expect to hear from you.
So I currently work at NAMI of Sarasota Manatee Counties in our Parents or Parents program, which we work with parents who are navigating dependency court cases. I have lived experience with dependency, lived experience with mental health, lived experience with substance use, and lived experience with a Suboxone doctor and with a MAT clinic.
Excellent, thank you. Sonia.
Hi everybody, my name is Sonia Johnson and I work with NAMI of Sarasota and Manatee Counties. I also have lots of lived experience with substance use, mental health, and I was on the Operation PAR in their MAP program for a number of years, and I was at, it wasn't New Seasons back then, but it used to be called Metro Treatment Center a number of years ago as well, and so I'm happy to be here and have this discussion tonight.
Hi everyone, I'm Laura Curran. I am Assistant Professor at USF Department of Mental Health Law and Policy. I come from a clinical background. I'm a licensed mental health counselor in the state of Florida, and I have experience working in the child welfare system. In cases of dependency cases in DCF, I provided in-home therapy for children and families who were experiencing substance use and domestic violence. I also worked at, I don't know if you all know DACO up in Tampa. I worked exclusively with the pregnancy caseload there. I provided mental health counseling for pregnant women who were receiving methadone and buprenorphine treatment. So I did a lot of case management type things and supportive services there. Been in research now, I think 10 years. I do research in the area of opioid use in pregnancy and tech-based interventions that are used in treatment programs. But I've done a lot of work in like access to substance use treatment for pregnant people and some policy work looking at different state policies that impact the ability to access treatment for pregnant people.
So thank you. And Siobhan.
And last but not least,
That's right.
my name is Siobhan. My name is Siobhan Clark. I am currently a practicing nurse practitioner at Lightshare, formerly known as First Step of Sarasota. I've been working for them for many years. My experience to MAT treatment started actually as a straight out of high school. I was a medication nurse, and that was where I got my first experience with treating and being a part of treatment plans for substance use and mental health dual diagnosed individuals. So I've been doing it for well over 20 years. I've now also, as I said, I'm practicing, and I've been practicing and prescribing the medication for this particular program for about the last 7 years, and recently, or 2 years ago, completed my doctorate degree, and my project was to implement treatment at my facility for pregnant women. So we now treat pregnant women at our facility.
Thank you. All right. Well, we will go ahead and jump into this. So we're going to lay out just really basic background about the medication, what it does, accessibility, and then we're going to jump into some of the more personal stories and talk about some of the real, again, challenges and real experiences utilizing the program in this area. So to start off with, our first question is, what is medication-assisted treatment, and how does it differ from other forms of addiction treatment? And Jonathan, I believe we're going to start off with you.
Great. So medication-assisted treatment, although it is a general term when you would say medication, what it was originally designated for was for opioid use disorder treatment. And it was specific to methadone, buprenorphine, which is the active ingredient in more commonly known drugs like Suboxone and Subutex, for the treatment of someone who is actively addicted or actively physically dependent on opioids. Opioids being painkillers, heroin, fentanyl, most people know what they are. And medication-assisted treatment implies that you use the medication to assist you with the treatment of the behavioral issues that they're experiencing. And so someone who's experiencing an addiction to an opioid, we generally use clinical services like counseling, case management, other things like that, while someone is receiving the medication. The goal of the medication is really to stabilize the individual and make it so that they're no longer experiencing opioid withdrawal, which allows them to be able to focus more on their recovery and getting progress through clinical services. In a nutshell, that is what medication-assisted treatment is.
Excellent. So what are the common medications that are used in MAT? And Siobhan, you may be able to speak to this.
Jonathan did mention buprenorphine, Subutex, Suboxone, Vivitrol, which is non-narcotic. So there is misconceptions about certain medications in the community. Vivitrol is a long-acting injection that is non-narcotic that is approved to treat opioid use disorder as well as alcohol use disorder. And then you have Suboxone or Subutex, which buprenorphine, as he mentioned, is the main ingredient that is used to, it could be in a detox situation. So you have an individual who wants to come off of opiates, and that will assist them to do that safely, as well as be used for maintenance, which is to just give them a safe environment where they're getting the medication that's controlled. They know what they're taking. They don't have to buy it off the streets. So those are the medications. Also methadone as well is also one of the drugs that is used for medication-assisted treatment. Did I get them all, Jonathan?
Yeah. The other we can include, Narcan, naloxone, the opioid overdose reversal tool. And it's important to note for Vivitrol, it is for a different stage of treatment where someone is not physiologically dependent on opioids, but they are still struggling with the desire to use, compulsion to use, and it's there to allow them, I guess, to give them some extra assistance on their road through recovery. Where it would be normal for somebody to, say, start on methadone, start tapering their dose down over time, maybe switch over to buprenorphine, continue to taper down off the medication, and then right at the end, when they're no longer physically dependent on opioids, switch over to Vivitrol, which helps reduce cravings, and it also makes it so that if they were to relapse, they would not be able to experience the euphoria that they would normally get. And just the knowledge that they're not going to be able to get high off of the drug usually will help deter them from using.
Yes.
Can you guys tell me about Sublocade?
So Sublocade is also a long-acting buprenorphine. So you know what Subutex or buprenorphine is, Subutex, Suboxone. Sublocade is buprenorphine only, so Sublocade is buprenorphine only, and it is a long-acting which lasts for 28 to 30 days.
How's it administered?
It is administered subcutaneously. So the approved site for Sublocade is to go in your stomach like would an insulin or a heparin if you've ever been in the hospital. So it goes like directly under your skin. You'll get a little bubble there. Some do, some don't. Just depends on how much you got going on in that area. And it's, it stays for some people, they'll have that, they can feel that medication not there. For some people, they can't feel it at all. If you can, it may stay there for a little while. So our 6 and 8 packers, they kind of shy away from it sometimes.
Last question, real quick. Sorry. How long does that show up on your analysis? Does it show up for the full 28 days?
That's a great question. So the long-acting buprenorphine Sublocade, actually, their insert states that you can be positive for buprenorphine for up to 1 year, and that's even with just one injection. So what we do, if there was a patient who wanted to discontinue services, they felt it was appropriate that they didn't want to come back anymore. We give them a letter. We do follow-ups and checkups with them for a full year so that they remain an active patient, and that if they had any issues with whatever, obtaining a job or having any issues with remaining positive, then we would provide that support to them.
Don't apologize for questions either. That's why we're here. So everybody jump in. All the questions you can have. Y'all will enjoy this a lot more, hearing them talk and having your questions answered than listening to me talk. But you did bring up some good points. So then for the group here, so what does it look like for somebody that's undergoing through the medication-assisted treatment? So like if you were to start, like how would you describe that process? Does it involve tapering? Is it indefinite? What does it look like there?
So I can answer that actually. It's a tricky question because everybody is going to have a different response to that. Everybody's life situation is different, their response to medications, what steps they're willing to take to further their recovery. So there is no really set game plan for when you come into treatment, you're going to be on for this long. The ultimate goal really is to titrate someone up to a stable dose where they're not experiencing withdrawal symptoms for 24 hours or more, giving them time to work on whatever underlying issues that they have in their lives that led them to use to begin with, and then eventually when they feel ready, start that tapering process with them so they go down the medication slowly and don't have withdrawal symptoms through the process. But the time frame, it's very different for every person.
So then last question before we jump into the actual experiences here. So what do we know about the effectiveness of MAT and whether it's used for special populations? Laura, I know you mentioned having some experience with mothers. So what does that look like in terms of the expertise and working with special populations like that?
Yeah, I mean, MAT is highly effective and it works and has a high success rate for pregnant folks. We were talking earlier about how the risks are lowered significantly when you are on a managed medication program, as opposed to the risks that come along with using illicit substances or using heroin while pregnant. Those are very high risks for miscarriage, birth defects, all these negative implications in your health. So getting a pregnant person on a stable dose of medication is really, truly life-saving. It can really stabilize someone's life. I think what it looks like in a practical sense is what I saw. A pregnant client would come in and then have a whole lot of questions about what and concerns about what this would do for my health and the health of my baby. So there's a lot of conversations that happen educating people about the safety of methadone during pregnancy, and it is. There has been no known studies or that have confirmed that methadone is related to any sort of birth defects at all. So I think people are, if you don't know, you're kind of scared of it. You don't really know what it's going to do, but there really isn't a high risk. So pregnant client would come in and get on a stable dose. Now, it's different during pregnancy. Like methadone would be typically every 24 hours you're coming into a clinic. But with pregnancy, your body metabolizes things faster. So food, literally anything. So a lot of the clients would do split dosing and do half in the morning and half at night. But I mean, those are just some thoughts. I do think the outcomes are much better because you're once you enter treatment, you're surrounded by a team of people that can support you better. So you're more likely to go to your prenatal visits. You're more likely to follow up after you deliver the baby, which is really, really high risk of relapse right after you deliver your baby. So that's a critical window. And if you're kind of already working with a counselor, already working with a team of doctors, that's like, really good safety net for you to continue your treatment.
It's also really important to keep in mind, some fundamental statistics with, both methadone and buprenorphine treatment. Is the longer someone is retained and engaged in treatment, the less likely they are to relapse after they discontinue treatment. And it is far and away the most effective form of outpatient therapy there is for a substance use disorder. And the way that it specifically is intended to work is not only will it get rid of the withdrawal symptoms, but it also provides a blockade effect at a stable dosage, meaning that not only do they not get sick, but even if they have the craving to use, again, the knowledge that if they were to use, they would not really be able to get high from it, which gives them a lot of help as far as being able to stay away from it. And some statistics too, at least through Operation PAR, after the first 90 days, we see about 75% of our patients who came in testing positive for an illicit opioid will be testing negative for an illicit opioid. And it's great for a lot of people. It's not for everyone, but for the people that it does work for, it's excellent. And the nature of it is that if it's at a stable dosage, it's not going to cause any sort of impairment at the same time. So people are able to function normally, or they should be able to function normally.
Yes, here.
I'm Washington Hill. I do not know, it's a pleasure to be here.
Hey, Dr. Hill.
Otherwise, I'd be home looking at the news. But Jonathan brought up a very important point, which is the longer a patient is on methadone, I'm sure it's probably true for some of the others as well, the longer they're going to be on afterwards, and after their pregnancy. I belong to another group, and we look at mental health deaths in the state of Florida. And it's amazing and unfortunate how many patients do well during the pregnancy, as was mentioned. They do very well, right? And then they go home, and life happens. And we then look at those cases and say, what happened? Did she go home with Narcan, etc.? But the point is very important that the MAP therapy helps these patients survive after their pregnancy.
Excellent. Very, very important information there. Yes.
So, 2 questions. So, I operate Freedom House, and so primarily we focus on a lot of women who are pregnant or who have delivered. In 2024, early 2024, we made a decision not to provide services to individuals that were taking that for a variety of reasons. And some of those questions would include when the after delivery, and you couldn't really get a straight answer, what does it look like for nursing moms on that?
I think you're going to get your answer.
I forget there's doctors here who can answer that too, so.
Yeah, no, y'all are back.
So I was a nursing mom on Suboxone, and I was very concerned with that as well, especially because I was a nursing mom on Suboxone who had a baby that was not born testing positive because it was on a very low dose. So it was a little bit like, I was like, oh, well, what does that mean? And they actually encouraged me to continue taking my dose and breastfeeding for at least 6 to 12 weeks before I even thought about coming off of it, because they said if there were any residual breakthrough symptoms that the baby was experiencing, it could ease them, but there wasn't enough in my breast milk that would cause a dependency. And they said breastfeeding is absolutely A-okay. And when I did decide to come off, I did discuss it in detail with the pediatrician before I made that decision, so that way I was getting the medical guidance. I'm sorry, I didn't mean to shoot my hand up, but I know there's a lot of misconception and a lot of judgment against moms who breastfeed who are on MAT, and a lot of people don't realize I had a DCF investigation right after I had my daughter, and I remember nursing my baby when the CPI came out, and she's like, are you supposed to be nursing that baby on Suboxone? And I said, I absolutely am. And I was, so, sorry.
Yeah, no, and I would say that's the number 1 question I would get.
Right.
Can I breastfeed?
And the answer's the same.
Yeah, perspective. So if I have a child, because one of the reasons we stopped taking clients with MAT is because it was a huge problem, and our relationships with Child Protection and the Safe Children Coalition are new.
Logistically, it's a nightmare to deal
So I really tried early 2024 to get information for education, to teach that caseworker that's coming out and trying to do, and it just became so laborious that we just said, we're not in that space right now to do that.
Yeah.
It is something we want to revisit in 2025. The other question is, so it's a sensitive topic for me in the essence that I know Matt is provided, but Matt is also provided with counseling.
Yes.
My question is a provider who is not connected to the clinician that is providing the prescription and the counseling. From the provider's perspective, how can we enhance our visual perspective on if the counseling is effective? We have actually pulled Matt completely from all of our programming because we really struggled with bridging the clinic. Like I would sit in a parking lot expecting to sit there for an hour for a full clinical therapeutic session, and the person is out in 15 minutes. And I'm like, did you see the therapist, but you got a prescription?
Yeah, so
So there's a difference between medication management appointments and therapy appointments. So what I would advise for your program maybe, or recommend rather, is that if you want to know what's going on, you can have them sign a release of information for what exactly, what type of appointment it is. You can have them, bring a note for you that says this is who they saw today, this is what they, this is what we covered, this is what we talked about. So I don't know exactly. I'm just trying to illustrate that there is a difference between medication management appointments and when they have their therapy. For us, it may be on telehealth. They may come into the office and do a telehealth in our office, or they may do it from where they live. For the therapy portion, there's also programs who have groups that they have to attend. But again, I do want to say that from the prescribing provider perspective, because we are in the business of saving lives, we're not going to hold the fact that they're not getting therapy or counseling against them, because we don't want them to relapse. And they're on a physically dependent medication, so I don't want to throw them into detox either. So once they start, it's up to us to continue to encourage them, have those conversations with them, and that's what we do in our sessions. If we know that they're not attending groups or therapy, we do try to encourage them. But again, if they're coming to see me, I'm concerned about their life. So that those, and then we'll and we do have in our team interdisciplinary meetings, and we discuss certain how can we help our patients get to those points of taking their therapy and their groups or whatever it is that we feel that they need. But it is not required for them to get a prescription. I just want to make that clear.
A good analogy to look at would be if somebody is going to the doctor because they have hypertension, they have high blood pressure. Doctor says, okay, well, I'm going to prescribe you a blood pressure medication, and I'm also going to advise that you engage in this strict program of diet and exercise. So that's going to help. So person starts taking the medication, lowers their blood pressure, and they initially start to exercise and diet, but then life gets in the way and they don't really adhere to this program very much. They go back to their follow-up appointment to the doctor, and do you think that the doctor would be like, well, I see that your blood pressure medication's working, but you really didn't diet and exercise as much as I would have liked, so I'm not going to give you your medication. It's like, no, they're going to continue to prescribe you the medication that is saving this person's life, while actively encouraging them to engage in other behaviors that's going to further improve their situation. And there is also a difference, between a licensed opioid treatment program where someone's giving them methadone versus an outpatient buprenorphine prescribing program. Presently, the Florida law indicates that there has to be some frequency of counseling for somebody to be able to continue receiving methadone through, like for an opioid use disorder. Buprenorphine, there isn't a law that establishes that. However, I'm of the mindset that, first and foremost, you got to keep somebody from overdosing and dying. And if you have someone who flat out does not want to participate in any sort of clinical services, and that's the only roadblock between them wanting to be on a medication that's going to keep them from dying, give them the medication. Like, maybe give them time or encourage them, give them more, information. But we really shouldn't be withholding something that could save their life.
I can speak to a more national perspective. Certainly the way that they teach that in the two previous states I've been in New York and Indiana, was along those same lines. As we wouldn't just deny somebody medicine for diabetes because they wouldn't stop eating at McDonald's or making dietary choices. Like, you're not going to let somebody die for some of the lifestyle choices sometimes. And same thing goes for methadone. So we had one question here, and then we had another one here. Let's jump here, and then we'll jump back here, okay? And then we're going to jump into the lived experience.
So I have many different experiences with, right? I was on maintenance for a couple of years, and it worked well for me in the moment, as far as I didn't die, right? Also, so I run a recovery home now, and I'm in recovery myself now, right? Not dependent on any chemicals, and so I have many different views on it. But my question is, like, a lot of times you see things overprescribed, right? Like, I don't think, my personal opinion is like 3 8-milligram tablets are completely unnecessary, right? Or it's personal, mind you, or like 350 milligrams of methadone is completely outrageous. I believe that's where people start to not be able to function properly under this medication. And so why do we continue to overprescribe?
I can answer that if you don't want.
The non-prescriber can answer that question.
Yeah. Well, so statistic for the 24 milligrams of buprenorphine, statistically that is actually the dosage level. Between 16 and 24 has the highest effectiveness for keeping somebody from relapsing. But it's important to remember that dosage levels are individualized, and it has a lot to do with, obviously, the level of dependency you've developed over time from illicit opioid use, or even illicit opioid use, where you develop this physiological dependency on it. But it's also a big genetic factor. So we've had patients at our clinic who are dosing as high as 600 milligrams a day, and they are able to function normally. And when they're at a dose that's less than that of methadone, when they're at a dose that's less than that, then they're experiencing withdrawal. And so the idea is that say you start low and go slow as far as tapering them up to an appropriate dosage. Now, there are patients that will pull a fast one on us and really manipulate the system to try and get the dose that we're prescribing them higher than it needs to be. And it's unfortunate, but it is, not the majority of our patients that actually do this, where the idea is that continue to go up until you're not experiencing withdrawal, but at the same time you're not experiencing any sort of sedation. And once they've reached that stable dosage, you keep them there and you focus on addressing all of the other issues that are contributing to the state that they're in right now. But as far as overprescribing is concerned, yeah, it's a concern, and it's something that we need to pay attention to. And realistically, how much you're able to prevent it on an outpatient basis, it's hard to say. So.
I think too, we have to remember that, like he said, everything's individualized, but there's also ways that we can address that oversedation through monitor numbers. So at least on a clinic level, every client that comes through has to get blood work done to show how their body can be responding to the medication. If we have somebody that's, say, at 300 milligrams and that seems like a lot, maybe they're overstated for the first 3 or 4 hours, but then they start having withdrawals in the afternoon and we can't really figure out why, we can send them for that specific lab work and potentially get them a split dose, which is where they would take half their dose in the morning and half their dose at night with a take-home bottle. So there are modifiers that we can do to prevent the oversedation and make them more stable over a longer period of time.
Can I ask you a follow-up question? What you were asking was about dose, like daily dose in the amount, so over prescribing in terms of the actual amount, but was also part of your question about over prescribing over a long period of time in a way that was you might consider too long to be on the medication?
Well, it wasn't, but it very well could be, because that's
Okay.
also a very like
That's
I know.
a big argument.
Well,
Yeah.
I know that. I'm so sorry. Oh, take over.
No, I really want.
You're asking all the really important questions.
Yeah.
Well, absolutely. Like I do know my personal opinion again with like Suboxone, right? I personally believe in it in a weaning sense, right? Okay, when you go into detox, they prescribe you Suboxone and they lower you over a course of a week, 5 days, whatever it may be, and therefore I understand it. But I also understand the maintenance level of it, right? Whatever it takes not to get someone to stick a needle in their arm, possibly end up dead on the side of the road. I can't judge that, right? But I believe at some point, right, at what point in length do we address the fact that, like, hey, okay, now we've gotten you this far away from your last use, you're stabilized, now at what point do we do something about it, right, and move forward from that point?
Well, moving forward can just look so different for everybody, and I know, like, I think the part of the pushback on trying to get people to wean off of methadone is because maybe, in some way, I think, that the medication was originally designed to be temporary. So, but we've realized its benefits. So I don't think you'd have any provider saying, I'm trying to get all my clients off of methadone. That's not really the goal. The goal is whatever the client wants and needs, and whatever will help them become stable. But I think there is part of that. There's in these conversations, there's part of this, well, are you gonna be on it forever? And that's kind of like not seen as in recovery. And I think anybody here would say that as long as they're in recovery, they're in recovery. It doesn't matter what kind of medication they're on in that process.
It's important to understand the difference between physiological dependence and addiction. So the addiction is the compulsion to engage in a behavior that's going to be damaging and have a hard time stopping from doing that. The physiological dependence is your body's response to the continued exposure of this drug. And so when somebody is taking in an opioid, a nervous system depressant, your brain responds to that by releasing a counter chemical nervous system stimulant, your natural one, adrenaline, in order to counteract the depressant effects of the opioid. And over time, if somebody's taking that drug, your body's going to continue to raise the baseline level of adrenaline over and over and over again, to the point where if you were to stop taking that opioid, what you're left with is an excess of adrenaline. And that, in a nutshell, is what withdrawal is. Now, you can have someone who is physiologically dependent on an opioid medication. Methadone and buprenorphine, they are opioids, just like heroin and fentanyl are opioids. But if they're not engaging in compulsive, self-damaging behavior that would typically be described as an addiction, then I would consider them to be in recovery. Now, the other thing is that 99.9% of the patients we treat, if you were to ask them, do you plan on being on methadone or buprenorphine for the rest of your life? They'll say no. And they don't want to be. Nobody wants to be dependent on any medication. But living in, being realistic about life in general, you want to look at, well, what am I risking? We have a number of patients that have been in treatment for 20 plus years, and we have treatment plans developed for them where they're stable on this maintenance drug, and we ask them, like, well, why are you still on this? And whatever they say, whatever their answer is, we're like, okay, well, if you don't plan to be on this drug for the rest of your life, why don't we work on that issue? But a lot of them, it's like, well, I got a chronic pain condition, and I don't have the money to get it addressed properly, or I don't trust myself to go to a pain management doctor, and this helps. And this is how I'm able to actually, freeze this problem while, maintaining my life. It's not perfect, but it's better than me risking relapse and going down that rabbit hole. So, we leave it up to the patient. Nobody wants to be on the drug forever. Most patients don't stay on it for more than like 6 months, but it's just about trying to give them some kind of improvement.
And just to follow up on that, there are some schools of thought for sure that teach that it is something that can be lifelong and that should be accepted as a form of recovery. Just because some people, that is what they need. Just like we wouldn't take somebody with diabetes off insulin just because we got the 1 year been on insulin mark. That the problem still exists and they're still thriving with the insulin. It's the same thing with methadone. We do the same thing. Yes.
So I had a couple thoughts here. One is we have medical alerts bracelets that people wear about medical conditions, heart, diabetes, things like that. Is there anything in place for someone who's on MAT that identifies that this is what they're on now, so that it, as an anti-stigma, I mean, if you're aligning MAT with the rules of other, diabetes drugs, insulin, things like that, would it make sense to have this be part of the medical alert system, or have a medical card that you carry that said, so that you're not discriminated against whether you're on MAT in interviews and various things like that? Is there anything up and coming in that area?
So for the long-acting medication, so it's a two-part answer. For the long-acting medications, which are, they're in your body once you get it from our office, and if something were to happen to you, you get into an emergency situation, we do give you a bracelet card and like a keychain or for the Vivitrol. We have one for that. For the Sublocade, we have one for that, and that's because those medications are in your body. Medical professionals need to know so that they don't give you something that's going to throw you into withdrawal. But the patients have to be willing to wear the bracelet. They have to be willing to keep the card on them in their wallets. There is nothing, I don't believe, or I don't know of anything that is something that I have to be, if I have opioid use disorder, then I have to be willing to let the world know that. And because of the stigma, even in our emergency departments, even for our pregnant women, they get treated so bad. Even for my elderly population, I have a patient that's 75 years old. He drives an hour to come see me because he doesn't feel comfortable going anywhere else. So there isn't anything that I know of that's out there that patients who suffer from this disease are comfortable with to wear openly. There are some people who are, and they don't have a problem with it. They take the bracelet when their Vivitrol wears off, they want a new one, But they're very few and far between, and so we have to continue to do things like this to increase or decrease the stigma for those patients, really. And it's up to them whether or not they want to disclose it.
And Elizabeth, Sonia, I'd like to hear y'all's thoughts on this, about what that might have been like going through a program if somebody had offered you something like that.
Specifically like a card or a bracelet?
Yes.
Absolutely not for
I can't imagine.
one, when I was trying to navigate 12-step, I would not, my medications and decisions I make with my doctor and my business, I wouldn't wear something and saying I'm taking amoxicillin for a sore throat, or I'm on this form of birth control, or anything else. So why would I need to? I don't think that would reduce stigma. Also, and please don't take this the wrong way, but I remember getting pulled over once with my take home from the clinic.
Mm-hmm.
And I remember the cop being like, call a K9, we got a junkie. And so to wear a bracelet like that, and like they searched my car and wanted to make sure, you know what I mean? And it was like a whole thing. And I just don't feel like I would have felt comfortable having to, or advertising it. And I don't think that it would reduce this. I think reducing the stigma is more having the conversation and understanding. And just to touch in a little bit on what Seth had asked, I think too, MAT is definitely a part of treatment, but sometimes MAT is also a part of harm reduction and just keeping someone alive long enough. And so I can understand not wanting to argue with someone when they're wanting to up their dose, because you don't want to drive them back to the heroin dealer. And that's how I kind of had to wrap my mind around it, like in peer work and things like that. When I hear some of the harm reduction stuff, sometimes I jolt a little bit. I'm like, ooh, that feels like enabling. But I have to remember that we just want to keep them alive long enough to build the skills.
Yeah, And I also agree with that. I would have never worn a bracelet or disclosed it to anybody because quite frankly, like everybody in my life that knew about it already was discriminating against me. And anytime I had any interactions with any sort of agencies, and when I was on it, I had interactions with DCF and they didn't tell me that I was allowed to stay on it. And so I actually detoxed myself off of it because I had a non-judicial case plan. I thought that's what I was supposed to do. My caseworker didn't tell me any different. And I know that things have changed over the years. This was 10 or 14 years ago, somewhere in that range. But had even like, let's say the courts approved of it, which they do today, the case managers, it may have a different view. You know, so there is discrimination all the way around as you go. But regarding what Seth was saying, I want to comment on that too, because when I was on the medication, I got up to 180 milligrams of methadone, and I was stable on it for a while, and I thought things were going well, and so I started to wean myself off. And what I would say is that people should just be able to make their own choices for their own recovery and do what they feel is best for them. And so when I explained to my doctor that I was ready to come down, it was like 5 milligrams every week or every other week. And so it took me over a year just to get down to 50 milligrams. And then that's when DCF came in. And so I was like, you know what, I'm just gonna go off of it. And it was a matter of months before I relapsed on heroin. And so we have a lot of work to do still in educating people. I felt like I was on, like, in what you said when we were having our conversation the other day was liquid handcuffs. I felt like, what if I did go to jail? Then what's gonna happen? Because back then, they didn't offer it in the jail. And so I was just afraid that something bad was going to happen because we had a lot of work to do still in education. And I think people just need to be able to make their own choices and then find their village and the people to support them in those choices.
That's excellent information, and I definitely want to continue on with this like kind of firsthand experiences talking about system interactions. I know you said you had a follow-up question, and then we got another one in the back here.
My other question was, how prevalent is it in a community of sober living houses to have support within the sober living houses for trauma restoration, for groups, for case management coming in, or is that always you have to go out to get that?
I think that's something Elizabeth and I can touch on as well. So as far as the medication-assisted treatment, actually right before this, we were discussing that Oxford House now goes into new seasons, which is amazing because what we're seeing today in this community is that now when you are incarcerated or when you do go to detox, you do get offered medicated-assisted treatment. And then you can then go to treatment and continue your treatment in treatment. But when you get out of treatment, you don't have anywhere to go typically because the sober living houses don't allow it. But Oxford House does. Yes. And so there have been, there is some pathway for those people to take. But a sober living house is a sober living house. And it's just one piece of the puzzle for that person's recovery. And so hopefully that person will find external sources for support, such as therapy or counseling or meetings or family or natural supports, whatever it is, they will hopefully have supports in the home and then also outside of the home. That would be ideal for their recovery.
All right, in the back.
First of all, Elizabeth, I just want to say I'm sorry for your experience with law enforcement. I can imagine it's pretty difficult for you. My name is Katie Patterson. I'm a reentry navigator at the jail for the Sarasota County Sheriff's Office. So my role, part of my responsibilities is to connect people with housing in the community while they're transitioning from the jail out into the community again. And one of the things that we sometimes run across is some of these sober living, transitional homes, halfway houses, they don't always permit that. And so that's one of the barriers we face. And I guess my question for the panel is, if I have someone that I'm working with that is really interested in one program that they feel they're a great fit for, and perhaps they're not allowing the daily dose of methadone or Suboxone or Subutex, but they would be open to an injection, such as Sublocade. What is the process of transitioning to, if they're open and they want to go to Sublocade for that reason, it gets them into a house that they really want to get in?
So your question is, yeah, you got
Yeah, I did.
So your question is, you're
Yeah,
asking how soon
transitioning,
can
yeah.
you take Sublocade?
Yeah,
So-
pretty much.
Okay, so basically, in order to be administered Sublocade, which again is a long-acting buprenorphine, is you have to be on at least 8 milligrams a day for 7 days
Okay.
in order to get your first injection, which is a loading dose, and there are 2 different dosages. So the loading dosages are 300 milligrams, and so after being on it for 7 days, you can get it. So if somebody's been on it in jail, all we need is a proof that they've been on it, and when they come for their appointment.
Okay, so if they get their last dose on a Wednesday, they get out, they get released, and on a Thursday, they have the potential of switching over to that Sublocade?
Correct. As long as they've been on it at least 8
Right.
milligrams
Right.
for 7 days.
Okay.
Something else to keep in mind, so the rough equivalent of, say, the maximum dose of buprenorphine on 32 milligrams is about 50 to 70 milligrams of methadone in terms of the strength. It's different for everybody, but it's like that. And so if you have someone who, say, is stabilized, that they have a physiological dependence that is high enough to require more than 70 milligrams of methadone, switching over to buprenorphine might just not work well enough for them, meaning that they are going to start going through withdrawal and it puts them at greater risk. So the idea would be, well, if they're able to do it, to taper down off of their dose of methadone until they can do a relatively smooth transition over to buprenorphine. When I say relatively smooth, I mean they are going to have to go through a little bit of withdrawal. There has to be some period of abstinence between switching from methadone to buprenorphine, but that would be necessary. In a perfect world, we would have sober living houses that are willing to accommodate both methadone and buprenorphine. But we'll get there one day.
Yes.
I just had a question. I'm Stacy. I work on Project 180, and I have been a manager of a sober living home. And I had girls that did Vivitrol, but it never let's not be long-acting buprenorphine because it doesn't show on drug tests.
No, so it's not buprenorphine.
Okay, but the Sublocade, what's the Sublocade is? So it would show positive for buprenorphine, like you said, after a year.
Right.
But how does Vivitrol?
So Vivitrol is non-narcotic and it's a blocker. It's more like the naloxone, and it does sit on the receptors that stop you from craving and basically reduce. If they were to use, they wouldn't, have any euphoria like you said earlier, and they would get sick immediately. They could go into precipitated withdrawal. So that's the way that it works. They don't have any, dependence on it, and it lasts for 28 days, like the Sublocade does.
And if I could add to that as well, so even if the person was on Sublocade, that doesn't mean that they could get into any sober living house that they wanted to go. And so if they are testing positive for any kind of opiate, they're not going to be able to get into most sober living homes. And I think there's reasons for that as well. So sober living homes typically are run by people who have lived experience in recovery. And so they don't have clinicians there or doctors there to monitor their dosages or make sure that everybody is following their medication regimens. And so that adds another whole set of complex issues to it as well.
And I think that's what I had encountered. It was like wanting to manage their doses, like the lockbox. They don't want that. And it's like, okay, well, if they have an injection, no one would typically know unless they had another rationale as to why they were, truly sober living, I guess. If they were of that mentality, then that would be a whole different thing. But I think it was a matter of just managing the doses and not wanting to cause facility management issues between residents and the home.
Had another question in the back.
And it's all related. So, yes. So for us, when we stopped in January of 2024, those were some of the big issues of, so problem solving is and I am very much about, your recovery is how you walk through your process and don't want shaming for being on that. And that was some other things that was happening within our house. No matter how much we provided education, there was still stigma. So from the lived experience, so maybe some ideas for, Project 180, for, programs like myself, and from the professional standpoint, what are some out of the box things? Because we definitely have seen some success, have seen tragedy, but there's still room to grow in that space. And our biggest thing was somebody getting prescribed 30 doses of strips or 30 days worth of strips, and then we have strips floating around the house, and then having to lock them and unlock them and things like that. So any ideas that you would have we would be open to, because I know there are other houses that would be open to it as well, but we're still in that same drug management space.
I think if you could maybe communicate what some of your issues are with it. Sometimes it's a matter of a lack of education, like the difference between Vivitrol, Sublocade, and methadone. I mean, they could come and or we could come and just talk about what you all think, because what you see in the outpatient setting, we see them, if we need to see them once a week, like building that relationship with your house so that you know that you can call and say, hey, something's not right with, Jane. Can you maybe see her more often? Or, maybe we have that discussion, maybe they should be on a different form. Maybe, they need a higher level. Maybe methadone would be better for them, So I think if we just build the relationships with the organizations, kind of like what it sounds like New Seasons, has or is doing, and you all can feel comfortable coming to us coming to you, to just have those conversations, then we can maybe help you tailor maybe a pilot a few. Maybe you would only accept them if they are in, a trusted program, and maybe that's the start.
Yeah. Is there a way, especially with the strips and the pills, could we say, yes, we do this, but if there's only like 7 days of medication prescribed at a time, or we had attempted that with a couple of different people, but then I also want to say from a lived experience, what does that look like? Because I know that that's more on you guys too.
My personal opinion is that considering that you have people that are not on the medication and you're considering maybe mingling them together, I personally don't think that's a good idea. And the only reason I say that is not to create more stigma, but if I'm 5 days in recovery and my roommate has Suboxone and she gives me a little piece of it, like it could potentially, somebody could overdose, like if they're the children, the reason I say that is because when I first started methadone years and years ago, I had a traumatic experience at the methadone clinic. I was going there and there were these children that went with their mother, and about 2 weeks after I started going to the clinic, the child died because he got a hold of his mother's methadone. And so I don't know, when you said that, it brought back that memory for me. And so I think that there's a right way to do it. And I don't know if managing every 7 days is the right way either. But I think more critical conversations like this is the right answer.
Yeah. We used to always watch them take their dose. Like they had to, if it was subs or strips or methadone, it had to be locked, and they can get their medication this time to this time. We never let it go around the house for all of those reasons. And so, like 2025, we're really trying to say, okay, can we have a medical clinician coming in and manage those meds without losing the validity of our program? Because I think that would be, a lot of it has to do with having a clinician on site that is able to monitor behavior, not all day, but to be able to see them periodically, to be able to walk through that. So
isn't that what they do in the jail?
Yes.
Where they distribute every morning or afternoon?
Oh, they do, yeah. We do it in our program. It's controlled. They get it from, in a residential treatment center. They come to outpatient. We prescribe it. Pharmacy delivers it to them, and then they have medication techs who watch them take their medicines. In certain units, if it's a pill, they have to crush it and float it or whatever. So I mean, there's different things that you can do, but I mean, this population is very clever. And you know, so there, you know, it's really nothing we can say that will 100% prevent, you know, incidents. But as long as you know the effort is there and your restrictions, I think if you're just willing to have, you know, some things in place. There are so many sober living homes that don't allow that. We have the same problem discharging people from detox. Like they don't have anywhere to go because they need not want it, they need it. So I'm definitely like, we just need to, you know, come together and figure out how we can all work together to maybe help reduce your fears. But you know, again, there's nothing 100%.
Logistically, it's going to require effort on the part of a sober living home to do it. I would advise generally, like for any abusable substance, to have it in a locked safe and have another person, you know, for some level of accountability. It doesn't necessarily need to be like a trained clinician or medical professional. It's just however you run the sober living house, as long as there's a trusted individual who's there to make sure that this person is taking their medication as prescribed and proceed, and then locks it back up. That reduces, you know, any sort of temptation for other people that are struggling in their recovery to, you know, go and get their roommates, you know, medication from them, type of
Can
thing.
I quote that to my board of directors?
I'd be happy to talk to them.
All the time, and my board of directors is like, nope. But I'm like, if we follow these protocols, we're not responsible at that point for the person's individual choices and decision making.
What I would say is, if you want to tell the board of directors to make them more eligible for public funding, then it's worth the effort to do that.
And these are all good points because, especially the part about John's contact information is on somewhere. The community collaboration's there, and that really is an important component about educating the population. Is events like this and disseminating knowledge about all of these different services, and then coming together to help address challenges like that. To be able to design these effective services, because there are protocols and ways to be able to do that where it will be effective, and it'll hopefully not have you pulling your hair out on certain instances. But these have all been great topics, so now I want to jump in because we've had some discussions about some of the experiences here. So Elizabeth, Sonia, I want to hear some. Elizabeth, we'll start with you. What is your experiences like with the system and just your insights?
So I've had several different experiences with buprenorphine primarily. I did once have a small experience with methadone as well, and I also tried Vivitrol one time. I thought I wasn't a candidate for Vivitrol because I had what I thought was a bad reaction to it, and I found out years later that because I had been on methadone for a period of time, that sometimes Vivitrol can cause some withdrawal to kick back up. And so no one warned me, so I had thought I wasn't a candidate for Vivitrol. So I think the first thing I would say is like education with even the people who are participating, I think is super important. So when I was seeing a Suboxone doctor, I definitely was not, I was going because in my mind I was like trying to do the right thing, but I was going because it was legal to shut my mom up and because I didn't want to be sick. I'm just being honest, you know what I mean? Like
effective motivation.
So I was going to a private Suboxone doctor. Sometimes they would drug test you, sometimes they wouldn't. They didn't watch you drug test. They would say they were going to have you see the counselor, but it always got pushed back. Like it never actually happened. Like they were never in the office when you came to your appointment. And I definitely was not taking it as prescribed. I was taking it in other ways, but it kept me alive. And I eventually came off of that, and I actually went into the Salvation Army, where you were my wraparound. I don't know if you remember me, but you used to tell me I had a warrior heart. So I'm glad to be able to see you now that I'm doing well. But I went into Salvation Army, and the detox was like rough. It's long. Like I don't know if people who haven't went through it know, but it's like 45 days of gator rolling. Like I remember times in jail detoxing of it, punching myself in the head, like praying for death. It was so bad. So it's rough. And so I eventually was in and out of jail, and I eventually got out of jail and had relapsed and overdosed, and I was like, okay, I don't want to die. And so I got back on Suboxone. And I would go through periods of getting it off the street, going to a Suboxone doctor, going to, what is it called now? PAR is who it was at the time. And I eventually got up to 32 milligrams a day, sometimes more. But I was getting 32 milligrams a day from the clinic. And when I eventually got pregnant, I wanted to wean down, and it was impossible. I know part of it was because I was pregnant, but I also know many people who aren't pregnant who have shared similar things, that it's not always the easiest thing when you go to them and you want to wean down. And I think that there can be a variety of reasons, but I do want to touch in on too how I got my dose so high. Part of it was me, but they were also, I was very encouraged to go up on that dose. And I didn't know any better. I remember going to the detox once, and the person asked me, do you need an Ativan? And I was like, no, I need 2. Being like a smart aleck, but it was because I don't know what I need. Like when I'm new coming to a Suboxone clinic or going to a detox, I don't know what I need. All I know is I don't want to be sick and I don't want to die. And so we put a lot of trust into the professionals. So when they're encouraging us to go up on our dose, we really think that that must be the right thing. And so I think, I hate to be the unpopular opinion because I'm very supportive of it, but I do think that sometimes like questions need to be asked before that, and some informed decision making needs to be had, because that was a really rough dose. And I did end up weaning myself down while I was pregnant, but I did not, it was very difficult, and I did not do it with anyone's approval. I actually researched how they do it in Switzerland, which is like one of the only countries that I could find studies for that they're doing it in. And I followed their protocols. I'm sorry, but I did, and it was very difficult. But I did eventually get myself down to 4 milligrams a day. And when my baby was born, she tested negative, and she had no withdrawal symptoms, and that was a big deal to me. Some of the I know I'm just jumping all around, but I'm just trying to hit on important things as quick as I can. Some of the things that were really difficult for me is while I was on the Suboxone, I didn't feel like I had a place in recovery. So I did a lot of online meetings. There was
down. It is really important. So we'll take questions on that for a second. If anybody has this. But Sonia, I want to jump. Laura,
sorry. You want me to
no,
wait?
you jump in, and then we're going to jump into Sonia. And then we're going to open it up, and I'm going to stop talking.
Thank you. Thank you for sharing your story. I was wondering, I can't remember if you said if you had experience with child welfare or
I did.
CPS
I
at all.
did.
What was that like?
So I had 2 experiences with Department of Children and Families, and the first one ended in what they call permanent guardianship.
Okay.
And so that is considered all on its own a maltreatment, which is a maltreatment is like a safety concern.
This was all in the state of Florida.
This is all in the state of Florida. So years later, about 10 years later, I was pregnant and I was on MAT. And so when I gave birth, I was double flagged. I was flagged once for MAT. Yes, and then once I was flagged for the MAT, they looked up my old case and they came out. And actually, when I came off of MAT, that was part of the reason why they removed my daughter, is they thought that I was at imminent risk of relapse because I was no longer
your second child.
with my 2-year-old. Yeah, they felt that I was at imminent risk of relapse because I had discontinued my Suboxone, which maybe I wasn't, maybe I wasn't. No one has a crystal ball to know, but that definitely played a part into it. But I can tell you that if I hadn't been on that, they would have been removing my daughter the second she was born because I would have been on that. So although it was painful to have my daughter removed and to be judged based off of being on the MAT program, it would have been much more painful to be in the full throes of addiction and then trying to work a case plan. I was able to reunify in 4.5 months. That never would have happened if I was in active addiction, and maybe me and my baby would have died.
So Sonia, jump in. Can we jump in? Say to say, and then we're going to do it all at the end. I want to make sure that we get every panelist the time to talk, and then we'll swing it back around.
All right, well, I'm just going to tell you that I was probably the patient that did all the things wrong. So initially, the reason that I went on the medicated assisted treatment program is because I didn't want to be dope sick.
Yeah.
And when I got on the program, I went up as high as I could, as fast as I could, because I was drug seeking. And actually that got me to a point where I got off of the opiates. And at that point in time in my life, I wasn't on any other unprescribed medication, although I was on benzos, which I know can be very dangerous for people who are on methadone, which is the drug that I was on. And I was in Florida when that happened, and then I kind of had like, I hate to call it a negative experience, but I felt a lot of stigma going to the methadone clinic every day and having to pay $15 a day for my dose, and then getting flagged, and then having to go do a drug screen, or getting flagged and having to go see the counselor, which was very minimal interactions, but I did have to go see a counselor. And so I just, and also there's like a crowd at the clinic, you know, and a lot of them aren't there to do the right thing. And so everybody wants a ride here and there. And so there's a whole environment with that. But, you know, I then moved away to Georgia with my husband, which is where we got married. We had kids. Life went really well for a while. And we started at a new clinic up there. And the new clinic was great because it was really small. We got a lot of intensive counseling and support. We had a great experience there. Like, my life was manageable. Everything was stable. We were getting take homes. Everything was going wonderful. But I never addressed the underlying issues. And so I came down to Florida to visit with my mom, ran into an old friend who did have my original drug of choice. And I was ready to move back to Florida. I just wanted to come home because I couldn't find that stuff up there, and I talked my husband into doing it. And then we came down here and went back to Operation PAR, and that's something that we had discussed in our prior meeting as well, is when I was there, because I was using that other stimulant substance, they flagged me and told me that if I didn't stop using it, that I was going to get medically detoxed, like rapidly detoxed, and I was terrified of that. And so, like you were saying earlier, like, you can't just take people off the medication when they're on the medication. And so I was terrified of that. And so at that point in time, the Metro Treatment Center had just opened. It was brand new, so I don't know if that gives you a timeline at all. And they allowed me to be on the medication and test positive for cocaine. And my life started spiraling out of control. I started titrating down on the medication. Because I was using the cocaine, DCF entered my life. And when DCF entered my life, there was just a lot of, everybody knows what's going on in my family, my natural supports. Everybody just, I felt so much shame from my choices that I thought the best thing to do would be to come off of the medication that I was on. Actually, that was the worst thing I could have done at that point in time, because I just got off at 50 milligrams. I was tired of being on it. I felt like I was stuck and I couldn't get off of it. So I said, I'm just gonna do it. The good thing about that is that my dad and his wife actually took me in during that time, and they let me not work. They let me just lay down and go through it. And I did. I went through it. I made it all the way through the detox, which was like 30, 45 days of a detox. Elizabeth is right. It's awful if you don't have the right support and do it the right way. Even under the best circumstances, going cold turkey is awful. But I made it through that. And then when I made it through that, I thought I was out of the woods, and I started using heroin again. And so that then put me in a very dangerous situation. And so from there, eventually I got arrested years later, and I wound up in the Sarasota County Jail. Had I had been offered medicated assisted treatment there, I surely would have taken it, because I went through a horrible detox in the medical part of the jail, which, if you guys have never seen it, it's essentially like a giant glass fishbowl. And they're watching you 24 hours a day because you are in really bad shape and at risk of dying or having a seizure or something horrible happening from the detox that you're going through. Now, when I look back in hindsight, I'm actually very glad that happened, and I'm glad that I went through that, because I use that as a reference point. So that's what, I never have to do that again, and I don't want to. But I can't. When I look back, like, I could see a lot of missed opportunities. I believe recovery is a holistic thing. Like, you should treat the person holistically. So there was a lot of missed opportunities. There was a lot of stigma as well. And because of that, I hid and I didn't share about it, and I didn't seek other supportive things in my life that would have helped me heal, because that's what I really needed, was healing it on the insides. So I think we have a long ways to go, and I think this conversation is critical. I think maybe we should start like a committee meeting after this where we continue these conversations. I mean, you have the right people at the table, so I think
All the right people.
yeah.
It's very true. You got a rock star. Man, next time you gotta add 30 minutes too. 'Cause we're down to our last 5 minutes now. I still got 6 more things to go on. All right. Well, thank y'all so much for sharing. I'm going to open this up now. There are 5 minutes. We'll start with you for questions. And while you guys got to multitask and think of the one primary thing that you'd like the audience to take away from, so we can go rapid fire to close things out.
Elizabeth, you mentioned that years ago, one of the 12-step programs, you couldn't get a sponsor. I assume that's because they felt that MAT is substituting one drug for another, and you're not really cleaning this over. Is that correct?
Yes, and it's also because I hadn't learned yet that I don't have to disclose all of my medical history with someone who's sponsoring me, that they are only responsible to walk me through the steps and teach me the literature. So if I would have known that, I could have kept my mouth shut about it, but it is absolutely, and it sometimes happens with psychotropic medications as well.
Do you think that's still a problem that a lot of groups feel that same way?
120%.
What can we do to change?
Teach people who are on meth that they don't have to talk about their medical care to people who are sponsoring them, and that they're to walk them through the steps and teach them the literature.
We discourage, I mean, not discourage, but we tell our patients, like, listen, you know, there's a lot of people who may not accept or understand it. You don't necessarily need to disclose that part about your treatment.
And at the same time, doing outreach and education like we're doing here today, because
Right.
it's one thing for the person to protect their own information, but we are also have a responsibility and a duty to educate the community and inform them about what we do and what our ultimate goal is. Like, we all work for different treatment providers, but we are all looking at this from the same standpoint. We don't want to compete with each other. We want to help everybody, and we only do that by working together.
And Christy, it works both ways, as you said.
And that patient empowerment piece about telling them what they do and don't have to disclose is very important and critically important for everybody else here who is, in a less vulnerable situation where you're not focusing in on you and getting yourself into a place where you're, happy and healthy and feeling better. It's the rest of us that are out there that need to be hammering this message home and making appointments with here. Oh, Laura, you had something to follow up on?
Quick point on that.
Yep.
I think that we have to remember that historically AA groups are very deeply abstinence based. So I think walking into an AA meeting and expecting to change everyone's minds is not going to happen. So and I think you have to have your own sense of community, right? So I think it was you who mentioned on a call, there's other groups for people that are in methadone maintenance or on MAT. So if you can create that sense of community, that's even better. That's what you want. And then everyone who is philosophically on this side and wants to remain very abstinence-based can do so also. And there should be supportive communities for everyone.
Space all around.
Okay,
Yes.
thank you. So I have a few more comments and questions, but then can you name any groups, 12-step groups that would be supportive of people on methadone?
You said Mara?
So there's a group called MARA International. It's MARA, Medicated Assistance Recovery Anonymous.
Okay.
And you can find it online, and they have recovery groups, 12-step format, where maybe somebody could find a sponsor if that's what they want to do, because maybe they want to go to the 12-step meetings or they want to do something else, and they should be able to do whatever it is that they want to do.
Okay. Then I have a few things. So just to verify, and then I have still questions or comments, that methadone, etc., this is very eye-opening for me, helps with pain relief as well?
Yes.
Okay.
Sure. So methadone and buprenorphine are both analgesics, like pain-killing medications. When someone's getting treated for opioid use disorder with methadone or buprenorphine, the goal is not, at least the primary goal is not to relieve the pain. Primary goal is to relieve withdrawal symptoms that would come about due to their physiological dependence. The analgesic effect of methadone lasts about the first 8 hours after you dose, and the programs are designed for the vast majority of people to do one dose per 24 hours. Now, we have certain exceptions where people are metabolizing it quickly, where they get a split dose and take it twice a day. But for the most part, individuals with chronic pain issues, they'll get relief during the first part of the day, but they need to do something about it for the next 8 hours, and ideally not a narcotic pain medication.
And so an observation and then a question. Obviously, this is very complex when you have mental health medications as well. Yeah, period. Yes. And then are there side effects that are expected with methadone and the other options? Okay, can you mention what they are?
So the normal side effects that you would expect from really any other opioid out there, the biggest complaints that we get from our patients, constipation and excess sweating. However, once someone's on a maintenance dose, most individuals, like their body will just sort of adjust and those side effects will go away. And if they don't go away, I mean, there's other ways that they can treat it through over-the-counter medication. But, nothing is perfect. Everybody experiences it differently. But nothing that stands out specifically with methadone, aside from one thing that is still pretty rare, but on really high, when I say high doses of methadone, it can sometimes cause heart issues.
Good evening, library.
Not to go too deep in the weeds with it, but it's something that's involved with the prolonged QT interval with their heart. Usually find it at super high doses, but we warn all of our patients about it, saying like if you start experiencing any sort of syncope, like dizziness or anything like that, like let us know first of all. Also, maybe go to the hospital if it comes to that, because it is a dangerous thing. We don't really see that with buprenorphine, which is it's a much safer drug. It's just a much less potent drug.
What over the counter is helpful for sweating?
Dr. Hill, or
I have no idea.
I stuff paper towels.
They do make vitamins specifically for individuals that are on MAT, and you can look them up really at any like health store or even on Amazon. I always read the reviews when I shop on Amazon, so if you go through and read them, there's people that are actually on methadone and Suboxone programs that are leaving reviews of these different vitamins that you could take that tell them how they relieve symptoms. But again, just like any medication, everybody's going to respond differently.
All right, well, it was 7:29 when the announcement came on, and that was like a minute and a half, so I was right on time. So do we have really quick, any final thoughts, words, anything? We have 60 seconds and I'm counting.
Just happy to be here, and I would just say to anyone who needs any additional information, the organization has our contact information. Please reach out to them and they can reach out to us so that we can continue this conversation. And if you have any additional questions regarding that, I'm happy to help.
Thank you. I would just say thank you for being here and sharing your stories, and it's been a long road, so just thank you, and success stories like this are the reason why I continue to advocate and research in this field, so thanks for showing up.
Sonia?
Well, I'm just happy to be here, and I hope that we can continue to have conversations like this.
Just real quick, so although it was very sporadically offered for me to do counseling while I was working with PAR, I would say if they had made it a mandatory thing for me to even do weekly, it could have been the difference between me not coming back anymore, because I just wasn't ready.
That was Metro, by the way, not PAR.
It was definitely
It was a
PAR.
PAR? Great.
No, in Sarasota.
Okay. Well, that's also Metro, but we can.
It was called PAR.
Well, I do want to thank everybody for coming and thank the panelists as well. And I think the one key takeaway for today is just MAT saves lives. That's the only thing we need to remember after this, right?
Just remember that perfection is the enemy of progress. This is a harm reduction type thing, and learning to accept that some level of improvement is success. Keeping people alive, priority, and being proud of someone making some improvement. Either they're going to get educated or they're going to improve a relapse prevention skill. Step by step, that's going to be really important to their recovery. And don't shame people that are putting in the effort.
Well, I'll hand it off. Thank you, I'll hand for the panelists.
Outstanding, outstanding. I must say, on behalf of the board, that this has exceeded our expectations. We were hoping for this opportunity, and it has just been fabulous. And I think everyone has said, the conversation has to keep on going. Whatever we can do to support you in this initiative, we want to be here to bring more events like this available. I would like you all to make sure you pick up our newsletter for the upcoming programs in the quarter. We are looking for additional board members, additional volunteers, so that we can expand our reach across our community, helping to end stigma and bring compassion into the hearts of the people that are struggling with addiction. And thank you all. I would like to end this meeting. And, yes, if you would all please fill out the evaluations, no matter what your role was in the room. It helps us with funding, it helps us to evaluate where we're headed and where we're going, and take a picture of our future programs. They're in the newsletter too, so thank you, Alan.
Personally, I want to thank my panelists for all the work they've put together. We've been working on this for a very long
Yes.
time, from the bottom of my heart.
Yes, thank you. Yes, and kudos to the Director of Education here for Suncoast. And thank you all for coming. Dr. Hill, really appreciate you being here too. So if we could just close real quickly with the serenity prayer. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. Thank you all.